Hey, almost time. Good afternoon, everyone. This is Professor Dunham, and I'm going to do a review for exam number 2. Exam number 2 is going to cover, let's see here, covers week 4 through 6. So let's go ahead and start with chapter 6. And nursing, chapter 6 goes over nursing care of the mother and infant during labor and birth. Okay, so let's see. Well, that was week 5. All right. I guess I'll work backwards. No, okay. We're going to start with what? Let's see. Let me see here. 4 to 6, week 4. I tell you, the time is going by so quick. Week 4 was 7 and 8, and then week 5 is chapter 6, and then week 6 is chapter 9. Got it? Okay, let me go ahead and share my screen. And if you have any questions, please, I'm doing this for you. Please raise your hand, use the reaction button on the bottom. Raise your hand, I can see it when I share my screen, okay? All right, this is for you. Also, under the resources, under announcements, there is a worksheet for chapter 6, 7, 8, and 9, okay? So I hope that you print those up and you can answer some of them as we go through today. All righty, here we go. All righty, so exam 2 review. Let me just make sure one thing. Okay, I am recording. Okay. Here we go. Okay. So chapter 6 went over some culture influences on birth practices. And yes, what I want to get across and for you to have for this exam is we have to be culturally sensitive. Okay. So that means we respect everyone's culture. And and I tell you, honestly, it makes the woman feel really great and at ease when the nurse does that. Okay. So for instance, I had a patient in labor and she was American Indian. Okay. And she belonged to, has a certain culture. Okay. And she asked me, could her tribe come into the labor room and do a ritual? And I said, of course. And they did. They came into the labor room. There was no problem whatsoever, and put her at ease. Let me tell you, this woman did her breathing and was in total control during the labor process. And guess what, guys? We had a beautiful birth, okay? We had a beautiful labor and a beautiful birth. And so that's what it's all about. And she did not have an epidural. She went natural. So that's what I'm talking about, being culturally sensitive to the woman, okay? And also, everyone is different. And so all our patients will have specific needs. So we need to play an active and therapeutic role and be a good listener. So again, we demonstrate culture sensitivity, okay? You might have one question on the exam on that. Okay, so let's go right into interpreters, okay? Because that was also in chapter 6. And so when you can and should use like an appropriate interpreter, such as maybe in our hospital, we have the blue phone. It's called the blue phone. And what we can do is use that phone and I can get any language that I need. Chinese, Creole, French Creole, Spanish, anything I need, I can get. That's the way to go. Because when you want to use an interpreter, you want to use someone that will interpret exactly what you're saying. You're the nurse and you're giving information to the patient. So you want to make sure that your interpreter is correct. So you might have a question on, should, you use a friend or family member, and it should not be a family member, because that wouldn't be proper. Okay, so let's go here. I see a brain teaser. So my brain teasers are questions. So which of the following nursing action demonstrates culture insensitivity in the care of the laboring woman? So that's how a question could be asked also. That would mean that the answer would be something that's insensitive. So which one do you think that would be? Well, the answer would be B, insist the mother removing her head covering, okay? Because some cultures, okay, they have the women wear a covering over their head because of their religion or their culture. And so therefore, having them remove that would be a prime example of a culture insensitivity. So that's how a question could be worded also. So what are we here? We're here to, discuss labor and birth and some complications. And we want to have a healthy mom and a healthy baby. So we're going to start out with the reproductive system. So this, let's see here. Let me just scoot down here a little bit here. Okay, this looks like this is chapter 9. So I'm just going to go right into chapter 9. And this is postpartum, where we have the uterus and we have process where the uterus reduces down in size. That's called involution, reduces the size of the uterus, okay? The uterine lining, remember, that's the endometrium, that's the decidua, and that will also get expelled when the placenta is expelled, okay? So here we're talking about the postpartum period, which is your chapter 9, the family after birth. So we're kind of going backwards a little bit. That's okay though. And then we have the descent of the uterine fundus. We involute every 1 centimeter each day. And you have like after pains. And these are all your key terms to this chapter. And those are intermittent uterine contractions. And then we have lochia, which is your discharge. And lochia rubra is the red discharge, okay? And then you have serosa, which is pink, and that has blood and mucus. And then you have lochia alba. So the first 3 days, 1 to 3 days after she delivers, okay, you'll have lochia rubra, 1 to 3 days. Then after from 3 to 10, it turns into a serosa discharge. And that is more blood with mucus. It's pink. It's pinkish in color. And then you have alba, which is white. And that would be from day 10 to probably almost to her total end of her postpartum period, which is 6 weeks. Okay. And the cervix will eventually go back down, and the vagina, the vaginal folds will reappear in 3 weeks. And then you have the breasts, and you may have some engorgement. Remember something. If she's breastfeeding, she could have engorgement. If she's not breastfeeding, she can get engorged. So when a patient is breastfeeding and they get really, really full, they have to empty quite a few. They should be feeding every 2 to 3 hours. They should be emptying those breasts. But what you can do to relieve the pain associated with engorgement is to have cold packs in between the feedings. And then when she gets close to feeding time, she can put a little warm compress on it to make it feel better for the baby. Okay, let's go ahead and skip down here. If she had an episiotomy, that's a surgical cut. So write down episiotomy. And how we're going to assess this is that we're going to use the mnemonic REDA, R-E-E-D-A. So this is how we're going to look at that episiotomy. So we're going to look at it to see if it's red. We're going to look at it to see if it's swelling, has edema. How about ecchymosis? That's another word for ecchymosis is bruising. And then, of course, approximation of the sutures, okay? So we want to make sure that those sutures, they line up, even with each other. And we want to make sure that, she keeps it clean. And then you use, a little peri bottle after every time she urinates or has a bowel movement. And never wipe, just kind of after she uses the peri bottle, put some nice warm water in it. And she squeezes that and cleans up the area. Then she can just pat dry. Okay. Now, at the first 24 hours, you put ice on the perineum. So you apply ice packs to the perineum. And that will really take down the inflammation. Okay. Remember, ice is your best anti-inflammatory. So it takes down the inflammation. And then after 24 hours, listen up, then you can use warm sitz bath. So that's a really good test question. So cold packs in the first 24 hours, and then you can go into a nice warm sitz bath from there. We also have some topical and systemic medications. You can have Duraplast. Epifoam is another one that's really, really good. Remember, she's delivered, so you're going to eventually have ovulation start again. And usually it resumes in 6 to 8 weeks if she's not breastfeeding. Now, if she's breastfeeding, okay, the ovulation period could be a little bit delayed. But remember, you have to breastfeed 10 times a day to prevent ovulation. And sometimes as time goes on, that may get less. And then you could get pregnant again if she ovulates. All right, so let's have a little brain teaser here. So which nursing intervention should the nurse include for a client immediately after the delivery to reduce bleeding and bruising of the perineum?
Apply the ice pack.
Yeah, apply the ice pack. This is a really good question to kind of take note to. All righty. So that was a little bit what happens afterwards. And now we're jumping backwards here. So we're going to go into contractions. Okay, because you probably have some questions on your test about a contraction, because that's the power, right, that she needs to open up the cervix for cervical dilation and effacement. So you got the contractions, they're the power. All right, now you have contractions, and there's 3 phases to a contraction: is the increment, the peak, and the decrement. The increment is going up, the peak is the top of that contraction, and the decrement is you're coming down. It's called decrement. And then you have the terms. Now, these are always really good to see again. So you have frequency of the contraction. So you want to know how often they're coming. So you're going to count from the beginning of one contraction to the beginning of the next contraction. That's frequency. So again, the time from the beginning of one contraction to the beginning of the next contraction. Duration is the time from the beginning of that contraction of a contraction to the end of that same contraction. Now listen up, hear me good. Duration is the time from the beginning of one contraction to the end of that same contraction. That's how long is lasting. And then intensity, how strong are they? So you put your 2 fingers on the fundus of her uterus to kind of palpate, very gently though, how strong they are. So if you touch your nose, that's a mild contraction. And if you touch your chin, that's an example of a moderate contraction. And if you touch your forehead, that's an example of a firm contraction. Okay. And that's how we actually teach new nurses coming into labor and delivery to palpate. And I do teach the LPNs when they come and help us, that I want them to, to see how strong they are. So we do teach the LPNs when they come and help us in the labor room, and they do so. Now also contraction, since it's the power, it also is used when she pushes. When she gets into the second stage of labor, she's going to start pushing. So you only push with a contraction, okay? And because you want the greatest force, okay? You want her body to help. So not only is she pushing with all her might, but also the uterus is helping her push that baby out. So that's why contractions are really, really important. So here's an example of a contraction cycle. So increment is going up the contraction. Okay. So during this time, you do some slow chest breathing. And as a labor and delivery nurse, you will help her or her partner to say, breathe nice and easy, slow and easy. Then as she gets higher, as you get to the peak of the contraction, here's the peak. Okay. And another term, and I know Hesse likes to use this term, is called the acme of the contraction. And that's the top of the contraction. That's the greatest force. And then as she comes down, okay, or decrease, it's called decrement. She's coming down. As soon as you can get her to slow down her breathing, is the better. Okay. Because remember, if she breathes really quick the whole time, then she could go into hyperventilation. So at the peak, she might change her breathing to maybe like a faster breathing, like really fast. But you don't want her to do that the whole contraction, because she could hyperventilate on. And then she would say, oh, I feel tingling, my mouth is kind of numb. And all you have to do is tell her to take her hands and put it over her nose and her mouth and just slow down the breathing. And that will help her considerably. And if you have a paper bag, you might have heard that works too. Then you put a paper bag. Well, but then everybody carries a paper bag in their child preparation bag. So I always tell them to use their hands over the nose and the mouth. Okay. And so here's an example, okay, of duration. See here, this is the blue area. So you begin at the beginning of this one contraction, and you time it to the end of that same contraction. That's duration. Okay. Now, frequency is counting from the beginning of one contraction to the beginning of the next contraction. Okay, so that's frequency. Now, those are pretty good questions to ask on a test. Okay, let's go here. Oh, and just to let you know, in the interval in between each contraction, this is like a little resting time for her. Okay, because the baby needs to recuperate too, because when you have a contraction, that puts a lot of pressure on the cord, which then would diminish the oxygen flow that the baby receives. So that's why we do not want a very long contraction. We like to see contractions from 60 to 90 seconds in duration. Okay. How long is less? And from here to here should be about no greater than 90 seconds. Okay, that's long enough for that baby to hold his breath during that contraction. Okay, so, and then we want the contraction frequency to be every 2 to 3 minutes. That gives her nice time in between and during the resting time for her to kind of regroup, get ready for the next contraction. Okay, let's see. I think I have another question. Okay, so write down, you want to know the definition of duration. You want to know the definition of frequency. Okay, and again, how does the nurse assess intensity of the contraction? We use 2 of our fingers. We put it on the fundus of the uterus, and we just palpate very, very gently. And again, it will be mild, moderate, or firm. Okay. Let's talk a little bit about Braxton Hicks contraction. You might see that again. So Braxton Hicks contractions, they are irregular contractions. Okay, now they don't serve any big purpose. They don't dilate the cervix, and they don't really efface the cervix. Even there's some studies out there that say they at least make the cervix a little softer, maybe efface a little bit. but we're not too sure. But when a person comes in and I'm triaging her and I had to assess if she's in true labor or not, I want to make sure that, I assess her dilation. If she's not dilating, then she could be having Braxton Hicks contractions. The body is getting ready, maybe for true labor to start, but it hasn't started yet. Okay. So when we're in labor, this is a cervical effacement and dilation. I just kind of go over here. So it shows you, the structures like the internal os. Let me make this a little bigger. Internal os, okay? And then you have an external os. This is your mucus plug in here, okay? And of course, the vagina. So when you're in labor, when I talk about effacement, with those contractions, that's where this internal os will get very soft. And you can see how here it starts to kind of retract upward. And then your external os will go ahead and open up. And then back in here, usually the mucus plug is no longer needed, so it's pushed out. The mucus plug, the function of a mucus plug is to keep bacteria from ascending up into the uterus. It keeps her free of germs, okay? All right, so I just wanted to show you that that's what the contractions are doing. The contractions are preparing, getting the internal os to come way high. External os is opening up. And you can see here how the external os has now opened up 10 centimeters and the baby's head will descend. Okay, so let's go here. So when we talk about the passenger, we're talking about fetal lie, okay? That's the position of the fetus in relation to mom's spine. Okay, so here, let me see something here for you. Make this a little bit bigger. Okay. Let me push this up. All right, so here, think of mom's spine. And so the baby here is head first. So that we call that cephalic position. All right. He's laying in a longitudinal line. So that's the lie, how the baby is lying inside. So this is good. This is the head down. We want that. Okay, this little guy here, he decided to go transverse. So mom's spine again, and this baby now is laying transverse in relation to mom's spine, okay? This baby here, transverse line, will be a C-section baby. This guy here, his head first, he is good to go. We call that cephalic position. Now, here's another little pictures of what happens to the passenger. Remember, who's the passenger? The fetus. The fetus is the passenger. Okay, so we talked about the power, which is the contraction. Now we're talking about the passenger. And so here you see a shoulder presentation. The shoulder is presenting in the pelvis. That would be definitely, that would be what? That would be a C-section. That baby just cannot descend. And also, you can't deliver that way. Okay. Now, Mr. Frank Breach, he has his feet up by his head. So what's presenting is his buttocks, the sacrum. Okay. This guy over here is called a full breach. He doesn't have his legs up. Mr. Frank, I learned to Mr. Frank because I learned that he's just showing off. He's just showing off everything he's got. So he put his feet up by his head. By the breach, she's just, very, she has her legs down and she just crossed, but she's just coming out the wrong way. She's coming off with what? Her buttocks first, okay? And then you have the single footling breach, which actually the foot can hang down right through the cervix, and you would feel it when you did a vag exam, you would feel the foot, okay? And I have felt all these presentations when I work labor and delivery. All right, so now you might have heard us talk about in different lectures about some presentations and positions. You may have heard say occipital posterior, which means the back of the baby's head, which is the occiput, is facing mom's posterior. So here's mom's pelvis, okay? So here's the posterior and here's the interior. So you can see how, you know, this baby coming down, he's coming down with his chin up. Okay, you see that? Where this little guy here is in a good position. He's in occipital anterior. That means the back of his head is facing mom's interior. Okay, this is a good position. RLA means his baby is lying, his back is to mom's right side, and he's got his chin down, and he's occipital anterior. And then this one is occipital interior, but and he's laying to mom's left side. That's what that is. So OA position is a great position to be in for vaginal delivery. Now, let me tell you, you can deliver your patient if she's in occipital posterior, but is the second stage of labor is longer. So that means your pushing stage is longer because it's harder to push this baby down and out when his chin is sticking up in the air. You know what I mean? So it's hard. It's hard on mom to make those turns that she needs to in the passageway. And hopefully she has a gynecoid pelvis because that's the most favorable pelvis for vaginal delivery. Okay. And here, I don't want to leave this out. This is OT. This is occipital transverse, where the baby's head is sideways, transverse. Okay, now you can, you know, she doesn't say she's in labor and you find she's OT. You can, the labor nurse can try to move the head to be an OA position or OP. Okay, we can't really deliver an OT because that is coming down with the widest diameter of the baby's head, and that's not going to fit through the pelvis. So that's why we try to change it from an OT to either even OP is better than OT. Okay, okay, this is just too hard to deliver. All right, then the other P. So we've been talking about the 4 P's. So we got the power, which is your contraction. We have the passenger, which is your fetus. We have the passageway, which is mom's pelvis. Okay. And then the 4th P is the psychic. Okay. And I'm going to tell you that this is very important. All right. Because the mental state really influences the course of labor. You know, other chapters you read about, you know, the doula. And a doula is a trained person who is an advocate for the mom. Okay. And sometimes, you know, the husbands don't want to take an active role. They just maybe according to their culture. Okay. And they just decided, I think I'm going to turn my head and I'm not going to be in there. Okay. That's okay. But mom needs support. So she hires a doula. Now write that down as D-O-U-L-A, doula. Okay, that's important. All right, so let's go over some signs of impending labor. All right, so we talked about already those Braxton Hicks contractions. Okay, I told you they're getting that body ready. Okay, her interior pituitary has to put out the oxytocin, which is a prostaglandin, which makes her uterus contract. So maybe, you know, she's starting, but they're not the real thing yet. Okay. Increased vaginal discharge. Yeah. Sometimes you have more mucus that's coming out now. Maybe you get the mucus plug that comes from up in the cervix, like I showed you in the other slide. Now that gets dislodged. That's a good sign that labor is going to come. And then, of course, if you have ruptured membranes, that's going to be, yes, you are committed to delivery. So hopefully she goes into spontaneous labor after she ruptures her membranes, because you have 24 hours from the time of rupture to the time of delivery, 24 hours. Got to get that baby out, because when you go past 24 hours, you can run into infection. All right. And then I'm sure you ever heard of somebody having an energy spurt, you know, they want to do the laundry. They want to, I mean, everything they didn't want to do maybe a couple of weeks ago, they want to do now. Okay. All right. So here, you know, when we do a badge exam, and we're checking for dilation in face of the cervix, I'm also going to check to see where this baby is in relation to mom's pelvis. Hopefully he's an OA, occipital anterior position. And here, I'm going to show you the station. So let me point out here. See these here little nodule right here? That's called the ischial spine. There's one on each side of mom, okay? This is her pelvis. So, and these are good landmarks. So we use those as a landmark to say we're at a zero station. Okay, so zero station is at the level of the ischial spines. Anything that's above the ischial spine is kind of high. So we go -1, -2, -3, -4, -5, okay? Well, -5 would be really high up. That baby will be called what we call ballotable, okay? All right, and that means baby is floating up and up above her pelvis, okay? So now go back to the ischial spine, because that's our zero, that's our landmark. And anything that's below the zero station, like +1, +2, +3, +4, +5, this baby would be born, that's a good thing. And a good question could be, you know, if the baby, if it's above the ischial spine, what would it be considered? -1, -2, -3, -4, the minuses, okay? And then anything below the ischial spines would be plus, okay? And that's how we tell where this baby's head is. And the lower, yes, go ahead.
So when it's down, like when it's +2, +3, +4, that's when it's getting ready, when the mother is getting ready to deliver.
Yes.
If it's -2, -3, that means the baby haven't dropped.
That's right. You got it. You got it. You got it. Very good. Okay. So let's go ahead and go over false and true labor. That's always a good question to have on the test. Okay. So let me go over false labor. So let me give you this little scenario. So you're the nurse and you're in triage today. Okay. So you have to decide if she's in true labor or false labor. You're going to keep her and admit her, or you're going to send her home. Okay. So it's always a hard job, because sometimes you got to tell them, not now, you didn't dilate, you didn't efface your cervix, so you're going home for a while. And then, you know, I had a lot of patients that would cry, and I say, it's okay, your body's getting ready, but you're just not in true labor yet. Because I'm looking at a couple things. I'm looking at the contractions. Remember the power? Okay, looking at the contractions, but they're irregular. Yeah, she's having some, but they're irregular. Okay. So there could be like 7 minutes, then 10 minutes, then maybe, you know, maybe another 7 minutes or 10 minutes. They're not just coming rhythmic every 2 to 3 minutes or every 5 minutes or every, you know, they're irregular. Okay. So I send her out walking. And when she goes out walking, actually, it relieves the contractions and makes the contractions go down in the intensity. Okay, so that's false labor. There's no bloody show, because what bloody show is when the cervix starts to open up, it sheds some blood, okay? And so when you have bloody show, that means that something's happening, that maybe the cervix she's dilating. So on this one, false labor, bloody show would not be there because she's not dilating or effacing that cervix, okay? And then here again, no change in effacement and dilation of the cervix, okay? And I usually send them out for 30 minutes. She comes back in, I retake her blood pressure, I check fetal heart tones, and I make sure that everything is okay. Then I can send her back out for another 30 minutes, okay? Now, then when she comes back, and she had a whole hour to change her dilation of the cervix, even effacement of the cervix, and she still didn't do anything. So I said, okay, go home, take a shower, relax. Sometimes they go to sleep. Have a little something light, clear liquids, you know, keep your stomach light, you know, so that when she starts getting regular contractions, that she don't have a whole bunch of food in her stomach. So you send her home. Now your next patient comes in, and this lady has contractions and they have a regular pattern. They're maybe every 5 minutes, okay, lasting maybe 60 seconds in duration, okay. So, and the intensity could be from mild, maybe to moderate, considering what's going on. And so you take her blood pressure and everything's within norm. You monitor the baby and fetal heart rate's within 110, when 110 to 160. So everything is good. And so you send her out walking. And when she comes back, she says, my contractions became stronger and more effective. Yes, in true labor, walking, ambulation will enhance those contractions. And then she's going to complain, my back really starts hurting me. And so that's a good sign too. Now on this, because she's in true labor, she will have some shedding of blood from the cervix, and that's your bloody show. Okay. So yes, your bloody show is there. And then you have progressive effacement and dilation of the cervix. So yes, maybe she came in and she was 2 centimeters and 80% effaced. You had her out walking. She comes back in, and you check her again, and now she's 3 centimeters and 90% effaced. Bingo, you're gonna admit her to the labor room. Okay, and she's happy. She's scared, but she's happy. So I have a question here. A laboring woman is uncomfortable and her labor has slowed down. Okay. So which instructions should the nurse give to the client to help stimulate labor?
Encourage the woman to ambulate.
Absolutely. Ambulation really increases labor contractions. Now that's a good test question. Okay, so here is an example of a monitor. This is continuous monitoring. So the fetal heart rate, I write it down, 110 to 160. Okay, so like anything below 110 would be called bradycardia, okay, a slow heart rate. And anything above 160 would be tachycardia, which would be a rapid heart rate. So we always want to keep between 110 to 160. And here, let me show you. Let me make this a little bit bigger for you. It's prime example of a continuous monitor. This is Hewlett Packard. So here your baby's heart rate is 113. Okay, again, it's within the norm. Here, this gives you the resting tone. Remember I told you the resting tone in between each contraction? And it should be around 20, but that's 22 is okay. And then here's her blood pressure. So you have the blood pressure cuff on her and you're monitoring her blood pressure. Here's her heart rate, 101. It's going to be a little bit faster because she is in labor. She's having some discomfort. She's working really hard. And so here you go. And this one here would be the pulse oximeter, but this one's not hooked up on this one. But you could get your pulse oximeter so you can really monitor her vital signs. Now, here, this side here is the contractions. So here's your contraction, and here's your increment, here's your peak, and then here's your decrement. Okay, and so when you're doing, remember we talked about duration? So we're going to count the boxes between here, the beginning of this contraction, right? Duration to the end of that same contraction. Okay, that's duration. And then frequency would be from the beginning of this contraction to the beginning of the next contraction. So her contractions are kind of far apart, are they not? And yeah. So
how do we know when a new contraction starts?
Oh yeah, you can see this here, this monitor, it starts to go up. This is what happens is mom's connected to the monitor through a togonometer that's on her fundus of her uterus. And that has a little a pressure gauge in it. So when her fundus of her uterus increases, okay, it pushes against that little pressure gauge and it goes up. And so then it draws these little lines. So it really is a great tool, to help us with knowing when a contraction is coming. And if it doesn't show up good, like this one here, this contraction didn't really show up. So maybe she may be moving in the bed. So you might have to adjust that toco on her fundus of the uterus. Now, that is the contraction. So here's the fetal heart rate. So let me show you here. Nice acceleration. Nice acceleration. So remember veal chop? Accelerations is A-OK. And so here I got good. So I know my baby is doing good. Then he comes down, he's got a low baseline, but that's okay. It's still within norm. And then he has another acceleration and another acceleration. So we're doing good so far with this baby. It's really a good tool, this electronic monitoring. Because years ago, I would have to listen with a Doppler and put my hands on the belly and know when she had a contraction. So I've been around the block a couple times, and this when we caught the monitor, when the monitors came out, we were so very happy. Okay, so here's an example. This is where the toco is. The toco, we call it a toco, T-O-C-O, and here it's on the fundus of her uterus. And here is the electronic ultrasound transducer right here, and that's picking up the fetal heart rate. Now these are connected. They have cords, as you can see right here, this cord right here. You can see how that cord is plugged into to the monitor. And here it is. Here are the cords, they're plugged in. So they're picking up the fetal heart rate, and they're picking up the contraction. All right, here she got blood pressure, as you can see here, and you can put a pulse oximeter and hook, and I'll have all these different cords hooked up. Okay, but this is a prime example of a laboring patient. Again, another fetal monitor strip. Again, this lady's not having any contractions, I can see. But meanwhile, the fetal heart rate is 148, so we're good within 110 to 160. All right. So again, this is just a slide showing if fetal bradycardia is below 110, fetal tachycardia is greater than 160, okay? And when we talk about baseline variability, let me go back to this slide here. Okay, let me show you here. When I talk about variability, I'm talking about these, see these squiggly, I call them these squiggly lines. I know that's not very, professional, but that's what they are. They're up and down. And what they are the baby's beat to beat cardiac activity, beat to beat. So when you have like a beat to beat variability of 5 to 25 beats, your baby's good. Baby's saying, hey nurse, A-OK in here. So this baby is good, okay? When you have, let me show that other slide, had a little less variability. Let me see, I gotta make it smaller here. All right. Oh, let me see this slide here. Let me go, here, right here. See here, see I have less of those squiggly lines, okay? So my beat to beat here is not as good as my monitor variability, okay? So I have less than 5 beats, but I have pretty good here, but right in here, I don't have as good. So that would fall under, maybe not absent variability, but it's not total moderate variability. Now, marked variability is when, let me see here, when you have these squiggly lines and they're going, let me draw it here. They're up and down like this. They're greater than 25 beats. That's marked variability. Now you see marked variability when you have a patient come in and maybe she just had taken some cocaine or smoking. The baby is reacting to that. All right. So a good test question would be about normal fetal heart rate, because that's what we want in the LPN role, and we want you to be able to recognize the normal fetal heart rate and maybe bradycardia and tachycardia. Now here's our veal chop, okay? So this is always good to know. All right, so the V stands for variables. And the variables are caused by cord compression. All right. That means what happens is the baby's heart rate has a sudden drop, okay, but a quick recovery back up to baseline. A sudden drop and a quick recovery. And what happens is the cord gets compressed. It could be like during a contraction or just for a contraction that the cord is going to compress, or the baby is himself holds onto the cord. It compresses it, but it doesn't last very long. Okay. And they vary. Sometimes they're in the shape of a V, sometimes they're shaped in a W or a U, but it's caused by cord compression. Now, early decelerations is caused by head compression. You know, I showed you the station as the head comes down like +1, +2. You might see some early because the head is getting squeezed, okay? And so his heart rate may go down, but that happens with the contraction itself. All right, and then you have acceleration, which is, I told you, A-OK. Now, the big one that you might see again is called late decelerations. Late decelerations, one, are bad, okay? They're non-reassuring, okay? That means if I see a late deceleration, I got to get intervention. I've got to do, put her on her left side, make sure she's got an IV, maybe give her some oxygen, because late decelerations are caused by uterine placenta insufficiency. That means that the uterus and the placenta is not giving enough oxygen to the baby. Okay, so that's never good, and you want to get that baby out as soon as possible, because otherwise your baby could be acidotic at birth. All right, so here, this is what a late deceleration looks like. So here you have contractions. You can see here she's quite you know, breathing hard, as you can see in the top, the acme of the contraction. You can see her breathing even. Okay. And they had, I guess, oxytocin on, and they shut that off when you have these recurrent lates. Because this baby's trying to tell you, I am not tolerating this at all. I have less oxygen coming to me, and I need help. You need to get me out, nurse. Because you can see you have some squiggly lines here. So you have some beat to beat. But you see here is starting to go away, and you're getting into the danger zone as absent variability. There is no more beat to beat, and baby saying, I'm in trouble. So these are what we call late decelerations. And again, this is a non-reassuring. As a labor and delivery nurse, if I saw this, I would not feel good about it. I would be on my toes. I would make sure she's on her left side and make sure I got an IV, giving her oxygen, you know, 8 to 10 liters. I'll probably give her 10 with all these lates, and tight face mask, okay? And I'm going to call the doctor and get him in here immediately. Turn off that Pitocin, okay? You don't want any more contractions. You want those contractions to die down a little bit, because baby can't tolerate it. He's in trouble. All right. So here, you know, if you have a nurse is caring for a patient in labor and she knows the fetal heart rate is in the 90s, remember, bradycardia, after a contraction. Okay. So which priority intervention should the nurse perform? Okay. So remember, I'm going to probably do all these except this one. I'm going to turn her to her side, right? I'm going to do that. And I'm going to, of course, notify the provider. And I'm going to have her take some good breaths, and she's going to have oxygen on. You never increase the patient's Pitocin. All right. So that was labor. So now let's talk about a very important fluid that's inside that uterus. All right. So we're going to look at, and we're going to look at the amniotic fluid. Okay. Baby is in amniotic fluid for 9 months. Okay. And that's the baby. The amniotic fluid is actually the baby's urine. And so, and all kinds of other fluid. And so here when we look at the color, okay, normal color is clear fluid. Okay. Now they may have a little flecks of what we call that white, you know, Vernix caseosa. That's the cold cream actually. It's very thick looking substance, and that's on the covers the baby when he's in utero to protect him from all this fluid. Okay. Now, if she breaks her bag of water and you see green stain or dark brown, that's not good. Okay, that means that baby had his first bowel movement, which is called meconium, in utero. Okay, so that needs to be noted, and that needs to be reported to the physician that the baby has meconium stain fluid. So because at birth, we're going to handle the delivery a lot different because it can compromise the baby and cause the baby to have respiratory difficulty at birth. We want to suction all that out. Don't forget, he's in the uterus. He passes first bowel movement. He's breathing it in. He's taking it in. So he's got it down in his stomach and his intestines and lungs. And so we want to get that out before he's born. Okay. So when the head is delivered, we're going to suction the baby. Okay. So we use the wall suctioning, and we suction all in the mouth and as far as we can. And then we take the baby, the next contraction, the baby's is born. We do not stimulate this baby to cry. We'll cut the cord and take it over to the radiant warmer and have RT there and the NICU nurse there, and they will do deeper suctioning. So usually the RT will put in a tube, ET tube, and so he can go ahead and suction all the way down into the gut, into the lungs, and to get everything up, okay? And so that we get as much meconium as we can. They usually do it 2 times only in the kind of a deep suctioning because it can lead the baby to have a lower heart rate with all that suctioning. So therefore they do only 2 swipes, and then they're out. And during the time that they're doing that, the NICU nurse is monitoring the baby's heart rate. All right. Now, on amniotic fluid, the fluid should not smell. Okay. It does not have a smell. So, and if it does, it may indicate infection. Okay. So, thank you. I'm getting ready for class. Okay. You're welcome. And then, okay. And then the amount could be scant, moderate, or large. Okay. So that's the inspection of the amniotic fluid. So if I gave you a brain teaser, a nurse caring for a patient in labor, and she knows that, okay, I think we just did that one. Okay. All right. How about another brain teaser? A woman in active labor experiences spontaneous rupture of membranes. So which nursing actions are appropriate at this time? So anytime that you have rupture of membranes, you're going to record the color of fluid. You're going to monitor the fetal heart rate for a full minute and record the time of the spontaneous rupture, okay? And record the amount of fluid. All righty. I talked already about a doula and giving support to a woman to help her cope with labor, okay? It does make a difference. I would also emphasize to you to know the stages and phases of labor, all right? So the first stage is dilation and effacement, okay? It can last from 4 to 6 hours. That's why you've got the 3 phases in that first stage of labor, all right? So we have the what? You have the latent or early phase, okay, where she's dilated from 0 to 3 centimeters. Then she goes into the active phase, which you go from 4 to 7 centimeters. And then she has transition from 8 to 10. Okay. The third stage, I skipped over the second. So the second stage is expulsion of the fetus, and that can last from 30 minutes to 2 hours. And then you have this third stage, which now she's going to deliver the placenta, and that can last from 5 to 30 minutes. And then you have the fourth stage, which is recovery or your postpartum period. Pain management in labor. So epidurals are great, okay, because they numb from the waist down. And the optimal time is during the active phase of the first stage of labor. That's when you dilate. Remember, from 4 to like 7 centimeters. Contractions are real hard. The head's descending, so there's a lot of pressure. And so that's that's why we call it an active phase. Okay. So, you know, transition is 8 to 10. You have, she's done all the hard work already. She's dilated to 8 centimeters and just needs a little bit more, and then we'll be able to push. So that wouldn't be a good time. So the optimal time is the active phase of the first stage of labor. Now, there's another pain relieving block that we can use. It's called a pudendal block. And the pudendal nerves are what happens is that they're blocked. And in your textbook, there's a really good picture, and it shows you where the pudendal needle will go. And what it does is going during the second stage of labor, the physician will go ahead and block those pudendal nerves. And so it gives her some relief when, that head is coming out. It kind of burns, and so it's a lot of pressure. So this gives her some relief. Also, if the physician needs to do an episiotomy, that surgical cut in the perineum, then he's able to do so, and she will not be in pain. Alrighty. Now, there's probably a big emphasis on non-pharmacological childbirth preparation in pain and pain management. So when we talk about preparation classes, we talk about like the Bradley method, the Dick Reed method, and the Moz method. They're all kind of the same, all control breathing, all have to do with the psych and relaxation of mom's body in order to let her body open up, dilate, and let the baby descend. So a lot of control, okay? It's good that they go to these preparation classes. Doesn't matter which one. It basically just go to one to get prepared for labor, because labor is like a marathon. It's not easy. And so she needs to have an understanding of what's going to happen, because when you have knowledge, you have power. When you don't get prepared, then you have fear, and fear can cause someone to have high anxiety and to be really uptight. So we don't want that. So be prepared. So some non-pharmacological, that means that these are nothing to do with medicine, okay? And a lot of ladies like this, especially in the early part of labor, when in that latent phase of the first stage of labor. She can use a lot of relaxation techniques, skin stimulation. Effleurage is really good. She rubs her tummy, and she can be doing some pelvic rocking in in a rocking chair that we have in the room. That's really good. It really works to relax the body. Then you have some sacral pressure that have sacral counter pressure, especially in the early latent phase of the first stage of labor, where she might have a baby that's in an occipital posterior position. And so that puts a lot of pressure on her back, and they have such back labor. So we can do a counter sacral pressure, and we put our hands, the palm of my hand, on her back, her lower part of her back, and the sacrum, and that really helps. Now, thermal stimulation works, diversion and distraction. I use a lot of imagery with my labor patients, and it really does wonders. Music, they can bring their music and they can listen to music. We have beautiful TVs in the labor room, and always go over controlled breathing. Another one that's not here that I use a lot of is hydrotherapy. Okay, we have whirlpools and we have showers, and I like to shower and get my patient in, because I can get my patient out of that shower a lot easier than I can sometimes get them out of the whirlpool. So Put them in a nice warm shower, let the water run over them, very relaxing. And when I see some more increased bloody show, that I know that is working because the cervix is opening up. So these again are non-pharmacological techniques, different positions. And that's another one that's on here. Positioning it works wonderful. Get them up out of the bed, as long as they're low risk patients and normal, and get them up, get them walking, get them on the birthing ball. Beautiful. They love the birthing ball. Get them in the rocker, let them rock. So different positions would also be another non-pharmacological technique. All right, so we have another different group of patients, and these are our what we call a VBACs, vaginal birth after cesarean. So what happens is maybe on her first baby, she had a cesarean delivery because the baby was in a breech position, okay? It had nothing to do with her body not being able to contract, but it had to do with the position the baby was in, so they had to section her. So as long as they do a low transverse cut on the uterus, she can VBAC, okay? Because there's always a concern with VBAC, okay? We're always gonna have to monitor the baby and her, gotta make sure those contractions don't get too hyperstimulus, because whenever you have an organ that's been cut on, okay, even though it's a low transverse cut, it does have a weakness. So that uterine scar could rupture. This is one group that you cannot give Pitocin as an induction of labor or an augmentation of labor. Okay, you cannot give her Pitocin. When she goes into labor, it has to be spontaneous labor on her own. That means that her pituitary is putting out the hormone oxytocin, okay, which will then cause, which is a prostaglandin, which will cause her uterus to contract. All right. So you got to be careful. So again, we're going to have the nurse will be watching the uterine contractions, the fetal heart rate, any bleeding, because this kind of patient could hemorrhage, and she may need more support. Every woman needs support, but she may need a little bit more support. Now, the nurse provides empathy and support, because I tell you what, I've had patients where they were VBACing, okay, and she stopped, her body stopped producing the natural oxytocin. So guess what happened? She ended up with a C-section, okay? She tried, and they get very, very down, very upset that they weren't able to do it, all right? So, they all need good support. And of course, we give positive reinforcement. I always tell my patients, there's two ways to have a baby. We're going to go for vaginal delivery, okay? But if we can't get vaginal delivery because maybe your uterus is not contracting, you're not responding to the oxytocin, or this is not a VBAC, this is a regular patient. I always tell them this. Then what we got to do then we got to do a section, okay? So there's two ways to have a baby. I tell my low risk patients or high risk patients, but not my VBACs. I tell them it's going to be either vaginal delivery or C-section. Okay. So the nurse is caring for a woman who's delivering her first baby. So which of the following indicates the woman is in the third stage of labor? So this is an example how a question could be asked to you. So you would have to know what's the third stage of labor. So we know what the first stage of labor is. The first stage is dilation effacement. The second stage of labor is pushing. Okay. The third stage of labor is expulsion of the placenta. Oh, and the question is asking, what's the third stage of labor? So that would be D. Okay. And the fourth stage of labor would be the 1 to 4 hours after birth. Okay. All right. So how about this one? The nurse is observing a patient for hemorrhage following a delivery. So which assessment finding indicates a maternal hemorrhage is occurring? So select all will apply. Okay. So we know tachycardia is our first sign of hypovolemic shock. So she probably is hemorrhaging and losing a lot of blood, and therefore her heart rate is tachycardic. Okay. She has a continuous flow of bright red blood. That's hemorrhaging. So that's again, I checked that, check the first one, check the second one. Saturated peri-pad ×3 within 1 hour. Those pads hold a lot of fluid. And then, so I checked that one, and she's passing large blood clots. Okay, I would check that one. So these are all signs that my patient is hemorrhaging. All right. A firm fundus at midline would not be, because that means it would be a boggy soft uterus, not a firm fundus. Okay. How about another brain teaser? The nurse assessing a client post-delivery knows that the uterus to be high and displays to the side. Oh, this is a good one. So which is the nurse's priority action? Okay, so again, the uterus is high. So after delivery, the uterus should be at the level of the umbilicus. Okay, so that should be right at her belly button, and it should be midline. It should not be displaced to the side. So again, what's lying underneath that uterus to push that uterus up and over to the side? That would be her bladder. So knowing that, I would choose assess for bladder distension, because she's got a full bladder. So next, how about another brain teaser? Which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum? Okay, well, I know, so she has an episiotomy, or maybe she pushed, okay, for a long time. And so she's got a lot of bruising and she's got some bleeding. So what am I going to do? I know that ice really works well. So here I would apply an ice pack to the perineum, okay? Because I'm going to tell you, oral narcotics is not going to reduce bleeding and the bruising, all right? So I want to get that bruising down. That bruising and the bleeding, the edema that usually occurs, you got to get it down. Okay, so ice pack for the first 24 hours. And then after that, you can give her maybe a warm sitz bath. All right. These are some obstetrical procedures you might hear. An amnio infusion. Okay, it's just like what it says here. You're doing, you're infusing back into the uterus, the amnio. Okay, so what you're doing is you're putting fluids into the uterus, and we do that by means of an intrauterine pressure catheter. Okay, that catheter, that's done by a certified nurse, and she has to be certified in putting these catheters in. And it's a sterile procedure, and we're putting a catheter right up into the uterus, and then we're going to hang a bag of sterile saline, normal saline, and we're going to infuse that slowly back into the uterus. Now that really does work well. I'm going to tell you when it works well. If you have a variable deceleration, like I talked about before, where the baby's heart rate goes down real quick and comes back up real quick and may happen again, that means maybe she lost a lot of fluid during the labor. So we can help those deep variables, okay, by putting back some fluid so the baby, the cord then can flow better, okay? It's not compressed. So the baby would get more oxygen that way. So we could do that, okay? That's one reason. Another reason too is when you have a baby that has meconium stain, had meconium in utero. And so you see this really, a lot of green, brownish fluid, and it's real thick looking even, it's you want to dilute it. So by putting in fluids back into the uterus, I can dilute that thickness inside that uterus, and that will be much better for the baby when he comes out than not doing anything. So, we can, that's why amniofusion works really well. Okay, now another procedure in the obstetrical world is an induction of labor. So just like it sounds, I'm going to intentionally start her in labor. Okay. So some people go up to 42 weeks and this baby has to come out now. So we may have to do an induction of labor because she's now really post-term and it's time to get her out. And she hasn't gone into spontaneous labor. And so we're going to help her a little bit. So we're going to use the drug and write that drug down. It's called oxytocin. Now look that drug up because that's one of the drugs you need to know for this exam. Oxytocin. It's a prostaglandin and it helps. And what it does, it gets the uterus contracting. All right. Now we have another way of dealing with some women that need to have an induction of labor. And this woman could say she's 42 weeks and her cervix is not dilated. She's like maybe 1 centimeter. Okay. And her effacement, that when we talk about effacement, the cervix is not paper thin, it's real thick. It could be anywhere like maybe 20% efface. Remember, it has to go to 100%, so it's really thick. And the head is above the ischial spine, so the head is in the minus area, maybe -2, -3, not good. And the cervix, when you check her, the cervix itself is not anterior, is posterior. So the cervix hasn't even come around yet. So we have a low Bishop score. And we use this Bishop score to be a guide, I should say, as if our induction is going to be successful or not. Okay, so a Bishop score of like 6 is the minimum. Okay, is recommended by the ACOG, which is the American Congress of Obstetrician Gynecologists. Okay, so anything below a 6, we're going to do like maybe a 2-day induction. So the first day, we want to get this cervix to get softer and maybe to bring it from a posterior position to an anterior position and see if we can get something started. Maybe a little dilation, okay? Maybe get the baby's head to come down would be good. So the first day we can use what we call Cervidil. So write that down. That's another drug you need to know, Cervidil. And what that is like an ointment. And we put that up on our glove. We use a sterile glove and we go up to the cervix and we're going to put it on the cervix. And that arm Prepidil will go ahead as another form of a prostaglandin and will go ahead and get the uterus to contract. That's a 2-day. Then she's contracting all day. You rest her at night. And then guess what? The next day you do your induction. Now, let me tell you something with the Cervidil. Because you're putting it up by the cervix and there's nothing keeping it there, you want to make sure before you insert that into her and by the cervix, you want to make sure your patient goes to the bathroom. Okay, you want to make sure your fetal heart rate is good. You make sure her vital signs are good, and everything's good. So because she has to lay there for like a couple hours, I put her on her side with a pillow behind her back, because you never have a laboring patient on her back, and let her rest and make sure that Cervidil is absorbed by her body. Okay, if you put the Cervidil in and then she says to you, nurse, I gotta go to the bathroom, and you can't tell her no because a patient needs to go, she's gonna need to go, so you're going to get her up, but guess what's going to come right down is the Cervidil. Okay, it has to be absorbed first. All right, so that's why I said that. let her go to the bathroom, because then you're gonna let her know she can't get out of bed for a couple hours so that the body absorbs the medication. All right. Now, another term, another procedure is called augmentation of labor. What you're doing is that maybe, for instance, you have a patient who went into labor. So low risk patient is not a VBAC, not a VBAC, and it's just a regular patient, and she was doing good for a while, but maybe you gave her an epidural. She wanted an epidural. Okay, she's about 5 centimeters, and her contractions dwindled. Okay, or they decrease. Okay, and so now you have to enhance her labor pattern that she had. We have to get her back to where she was before the epidural. So we're going to use the oxytocin. We're going to use Pitocin, which is the synthetic form of the hormone oxytocin, which is a prostaglandin, which will enhance her labor. And you get her back into a nice labor pattern. And if she has an epidural, she'll have a Foley catheter in. That helps keep the bladder nice and empty. And so the baby then can have a better time coming down while she's not feeling any of that because she has a beautiful epidural. Okay. Now, we talked about labor induction, how good, when we're going to use it. But these are some what we call contraindicators, okay? Contraindications to inducing someone. So you would never induce anyone who had a placenta previa. Because remember, with placenta previa, that, placenta is laying right over the cervix. So if you induced her, you would have a hemorrhage. She would bleed out. Okay, so you do not induce a placenta previa. You never induce a patient that has umbilical cord prolapse, because that cord has now dropped down into the pelvis, and that could kill the baby. Okay, and so this here umbilical cord prolapse is actually an obstetrical emergency. So when you do a vag exam and you find a cord hanging and it's pulsating, that's the umbilical cord, and you must not take your hand out, leave your fingers there, push the baby's head off the cord so the baby can get some oxygen, because when the cord prolapses, the baby's head can put pressure on that cord, and he cuts off his own oxygen. Okay, so you're going to press the emergency button with your elbow, which I have done lots of, and get the team in there. Okay, anytime you have an abnormal fetal presentation, I talked about the shoulder and the breaches and the transverse lies, that's like normal fetal presentation. You do not induce labor. A high station of the fetus, remember that plus, -3, -4, -5, that's considered a very high station. The baby's floating, you're not going to induce labor. Anytime you have an active herpes infection in the birth canal, you're not going to induce, because you do not want this baby to come through the active herpes infection. Again, if mom has an abnormal size or structure of the mother's pelvis, such as, for instance, if she has that planetoid shaped pelvis, that you can't get a baby through that. You don't do a labor induction. And then, of course, if she has a previous cesarean incision, okay, previous cesarean incision, you're not going to give her oxytocin. All right. So let's now talk about complications during labor and birth. Okay, so I already went over with you the induction or augmentation of labor, the Bishop score, and amniotomy is artificial rupture of membranes. So as L&D nurses, we make sure that if a physician is going to break her bag of waters, that our responsibility is, if I have a lady that is at a -3 station, I will tell my obstetrician, no, we cannot break her bag at this point, because we could have a cord prolapse. Okay, if the baby's head is really high, and he breaks her bag of water, that cord could just float, really could come right down. So we don't want to do that. I have been in that circumstances where in the morning, late, she came in to have a labor induction. So we get him going. The physician comes in. He says, okay, I'm ready to do the AROM. We call it AROM, AROM, artificial rupture of membranes. And I said, I checked her and the baby's is not engaged. It's really high, doctor. So he says, oh, okay. I said, give me in the morning, give me this morning to get her going, get her in good labor pattern, and come back around 1 o'clock, around your lunchtime. And we can do an amniotomy by then. Okay. Because then I know I can get that baby's head down. So that's how we do it, because we don't want to create a problem. We don't want to create a prolapse cord because we did too early of an amniotomy. And when you do an amniotomy, you always worry about fetal heart rate. Okay. So I'm always going to be checking the fetal heart rate and make sure baby's doing okay. What's the color of the fluid, your assessment of the amniotic fluid, and is there any odor, and keep your patients dry because you may have a lot of fluid that comes out. And so, you want to prepare. I usually put a whole bunch of chucks down and I actually put a towel down too. And so I can dry her off, and I preserve the bed that way from getting all wet. So, those things are pretty good. But again, you want to make sure you always know the fetal heart rate. Okay. Now, the amnio infusion we talked about already. So we'll go over that again. The version is when the mom has a breech presentation and she really wants to have a vaginal delivery. So maybe about 37 weeks gestation, we bring her in under ultrasound guidance and change her from a breech presentation to a vertex, okay? And get that head down and head presenting. Episiotomy is a surgical cut in the peritoneum. It allows more room for the fetal head to come through, okay? So episiotomy, because it's a nice surgical cut, it heals better than, say, a tear. Because if you don't do episiotomy and you try to control the head when you deliver, but sometimes the tissues are so fragile in peritoneum that they just will tear. All right. And be sure to go over the different types of episiotomy lacerations, 1, 2, 3, and 4. What happens is that on the 1, you're just cutting in the superficial, top layer of the skin. And each time you go a little deeper. By the time you get to if it's the 4th degree, you're down into the anal area. And that can be very painful. All these episiotomies, lacerations are painful. Now, these forceps and vacuum extractions, these are what we call assisted device, where during the 2nd stage of labor, maybe she's been pushing for a couple hours and the baby head doesn't come out, okay? She just can't get through that, that bone, symphysis pubis. So what happens is that the doctor will use forceps. They are stainless steel blades applied to baby's head, and she pushes with a contraction, and he pulls a little bit and helps guide the baby out. Now, a vacuum is the same kind of assisted device, okay, except it has a little circular cap to it. And what happens is that it's connected to a little pressure pump, and the nurses, we can control the pressure on that pump. And then while she has a contraction, she pushes, and then he'll use counter pressure to help bring that baby through. Okay. Sometimes your patient just gets really tired of pushing. That 2nd stage just goes on and on, especially you have OP position, and mom just is worn out. So sometimes you have to use these assisted devices to get these babies out. Cesarean section. It's also another complication. Remember I said there's two ways to have a baby, vaginal cesarean. And anytime you do major surgery on anybody, it is major surgery. And so you have to realize that you have to have a recovery time. So after you come out of the OR and labor and delivery nurses, we do our own cesarean sections. You know, obstetrician be the surgeon, of course. We have anesthesia in the room. We have a scrub tech, which happens to be a lot of our LPNs are really wonderful surgical nurses. And we have the radiant warmer in the room. And then the RN that's been laboring the patient, she is the circulating nurse. Okay. And then after you come out of the OR, you go to recovery room and you'll recover your patient. And sometimes the L&D nurse have been with the patient the whole time, she actually stays in the recovery room with the patient, which is nice. Now, sometimes you have to give a report off to another nurse who that's her duty that day. She's in the PACU, so she has to be in there. But it's always nice to be able to recover your own patient. Okay. Again, it is major surgery. Another complication during labor and birth is when you have labor dystocia or abnormal labor. You just really, you try really hard to get this lady into a regular rhythm, and it just doesn't happen. A lot of times I see this with induction of labor, where you try to get them into a good labor pattern, and due to the size of the baby, position of the baby, it just doesn't happen. It stalls out, we say. And that's problems with the powers of labor and birth. We talked about those 4 Ps. Sometimes you have problems with the passageway or the power, and sometimes the fetus itself, and then and mom, the psychic, she just has a hard time relaxing, and it's just not going the way it should. A breech delivery, again, is a complication, because she comes in and she's quite dilated and she's breech. In the United States, we deliver these babies cesarean. So that would be a stat C-section if she was quite dilated. And if she was contracting a lot, you could give her tocolytic to slow down the labor. Now, precipitous birth is a very quick birth. You labor and birth all within 3 hours. Okay. And it's because they have what we call hyperstimulation of contractions, where you have contractions one after the other. Okay. It's good in a way and it's bad in a way. Okay. So what happens, she has this intense contractions and they're one after the other. Now the baby, no, don't forget, he has to get his breath in between. And so baby could have problems too. Baby could get injured coming down the passageway really too quick. He's hitting bone, and he could cause himself to have intracranial little hemorrhages, and that's not good. So in a way it's good, in a way is not. That's why I say that. Also, mom can actually hemorrhage after a precipitous birth, because don't forget, the uterus has been contracting really one after the other, every minute. And so she has this, what we call tachysystole, which another term is called hyperstimulation. And now she delivers. The uterus doesn't want to contract anymore, but we need that uterus to contract in order that she doesn't hemorrhage. So you can see where that could be a problem afterwards, because the uterus just says, I'm tired, I'm not going to contract anymore. All right. And then another complication could be that your patient went into preterm. Okay, so preterm labor, and then she delivers. We always try to keep our patients from having a preterm birth. All right, so we give a drug such as magnesium sulfate. Yeah, you probably say, well, we give that drug too for patients with preeclampsia to prevent a seizure, but we also give it for preterm labor because the mechanism of magnesium sulfate, it reduces the sensitivity of the central nervous system, reduces all that. So it reduces in the brain to prevent a seizure, and it reduces the sensation for the uterus. So again, it's a good tocolytic. That's a group that I want you to look up. It's called tocolytic, and there's two. You can use brethine or terbutaline, and that's those are tocolytics and magnesium sulfate. Okay. Then the prolapse cord we already talked about. I already talked about uterine rupture. And then that last one I want to talk about is amniotic fluid emboli. And that can happen. What happens is that you have a patient and she delivers. And the amniotic fluid gets into mom's circulation. Okay. And it travels up to her lungs and heart, and causes her to have complications such as hypertension. She has respiratory difficulties, and you can lose your patient very quickly. Okay, this is not a good thing. I've had a patient that I labored her. We ended up with a C-section. We went to have a C-section. Everything was going fabulous. The baby came out, went to the radiant warmer. Daddy was over there by the baby. Everything was going good. And all of a sudden, she couldn't breathe. Her blood pressure plummeted, went really low, and we lost the patient. We tried to resuscitate, and she didn't respond because she had like an emboli that just attacked her. Okay, very quick death. All right, so it does happen. All right, another complication that I think I touched base on already, but let me go a little more detail for you, is the perineal episiotomy laceration. All right, so here you have your first degree, which I told you was superficial vaginal mucosa. Second degree now, you involve the vaginal mucosa, now the perineal skin, and now you go deeper tissues of the perineum. And we all know where the perineum is. And the third degree, okay, so you have everything you have is like second degree. And so now you're going to have the anal sphincter involved. Okay. And then your fourth degree, you now extends all the way down through the anal sphincter into the rectal mucosa. Those are really, really, really deep episiotomy lacerations. If you have a patient that had a third degree or fourth degree, you definitely going to have her on high fiber diet, lots of water. She's got to, you can't have her constipated. She's got to be able to have stool softeners, because this kind of patient would be scared to death to have a bowel movement. And so what happens is that those fourth degree, that baby was just too big. Okay. And so they had to cut her all the way in order to have plenty of ability of the skin, everything just to open really wide to allow this big baby through. Okay. It is painful. There's a lot of, we have to sew up quite a bit. And they have a lot of stitches. So you would definitely have ice packs on her. And then, you get her the next day into a nice warm cis bath. Got to make sure that, you don't get her infection. Got to have ultimate hygiene so that she doesn't get infected. I already talked about forceps when I was going through that. So if you want to, read again about the forceps, here it is. And here's a picture of the forceps. You can see these are stainless steel, and they don't give. They go right on the baby's head, one on one side, one on the other. And this here actually locks into place so they don't come loose. And then the physician will hold this end right here. And mom pushes, okay? And she pushes, and the physician will use this to help bring the baby down, see? And so these are actually forceps, and they are still used today, okay? So you can see where this can cause trauma. It can cause trauma to mom tissue, okay? And it can cause trauma to baby. Here's that vacuum extractor, okay? So again, with vacuum extractor, you're gonna have You know, the head is going to be presenting ossicle. You know, you can't put this on a breech. No, no, no. And again, it's used during the second stage of labor to help with mom's pushing efforts. This is exactly what it looks like. And so, see, you put this right on the baby's head, and that causes that baby to have a little mark when he's born. It's a circular indentation on his head. It goes away. It goes away. And here you can see the pressure. So the physician puts this on the baby's head, not on the sore spot, be on the side of the head. And then the nurse will be holding this and with the pressure. Okay. Now the forceps can cause little marks on the fetus's head, side of his head. And so you might see that at birth, those little red marks. So basically, it does go away. If it's a real tough delivery, baby can have facial paralysis, which is not good. Okay, so you gotta be careful. So again, you have risk when you use forceps or a vacuum extractor. You have, as I said, trauma to the maternal or fetal tissue. Mom can have a laceration or hematoma in her vagina. A hematoma is very, very painful. And so, but because that perinatal tissue is so soft, so fragile, and it's thin now because, you know, everything has been stretched open, it can cause hematoma. And hematoma is very painful to the patient. Infants can have bruising, like I said, facial, scalp lacerations, or abrasion. Vacuum extractor can cause a septal hematoma, which can happen on the side of his head. And that's, again, a collection of blood on his head. It will go away. It's not pretty at birth, but it will go away. Babies can actually have intracranial hemorrhage if that forceps is not used correctly. So, or the vacuum not used correctly, so it couldn't cause it to bleed. So if I asked you, what would the nurse expect to assess an infant who was delivered with assistance of a vacuum extractor? And I hope you would say D. It's a cervical edema of the scalp. All righty. Which will the nurse expect to observe in an infant delivered with a vacuum extractor? The cervical edema of the scalp, right? Okay, I think that's just the same one. All right, nursing care. All right, so we have now the fourth stage of labor, which is our recovery, which would last, she'll be in the labor delivery recovery room for like 1 to 2 hours, and then she'll go to postpartum. So you do your vital signs, temperature. Remember, you gotta remember to keep her afebrile. You know, she starts running a temperature. It's not good, but you know, she may have a little bit of a rise for the first 24 hours, but it does go down. Okay, I usually give my patients some hydration with water. Water at the bedside, and usually is okay. Pulse. It's normal to have bradycardia after birth. Okay, so if a patient has a high pulse, that could be an indication of a infection, or even worse, she could be going into hypovolemic shock. Okay, so you want to check her fundus real quick, make sure it's firm, look at her loci rubra, and make sure she's not expelling a lot of blood. You're going to check for edema. So you may have edema in some lower extremities. That's normal. But again, anything when you have edema that's above the waist, that could be a bad indication of pregnancy-induced hypertension. And then check the legs for thrombus, because again, she's more prone to her DVT. And remember the Holman sign. So I know in your book, you have the mnemonic bubble heat. So go over that. I believe that's in chapter 9. Go over that. You're looking at, you know, bubble heat. So it tells you exactly what you'd be checking for. Okay. Remember the urinary system. The kidneys will go back to normal at the birth. Yay. And a full bladder can displace the uterus and lead to postpartum hemorrhage. All right. Cesarean, we went over this already. and here's a little foot coming out here. Here's a cesarean. Here's how you cut into skin. This looks like they do a transverse cut here, and you go into the layers and get them and go right down into the uterus, break the bag, okay, and then get the baby out. All right. When you have twins, this can cause a dysfunctional labor. Remember we talked about labor dystocia. The uterus can get overdistended, which then leads to poor contraction quality. So, you could get her like delivered, and then you have to worry about her fundus staying firm because the uterus was overdistended because it housed two babies, and it's a lot of weight, and the uterus can stretch. Okay, now it has to, babies are delivered, the uterus has to go back down. Okay. All right. This is a good test question. It's like one of those questions that you want to have all that apply. So your nursing care following a cesarean birth. So, you're going to do the same, normal vaginal delivery, and you're going to do a little bit more. Okay. So, I should say, except should be in addition. You want to monitor the abdominal dressing. All right. So she's going to have this big pressure dressing on her abdomen, and you want to make sure that she doesn't bleed underneath there. Yes, you are going to do a fundal assessment. The fundus of the uterus needs to stay firm, because if you don't, and she gets boggy on you, she'll bleed, she'll hemorrhage on you. So that's never good. And then you have lochia. Lochia is a little bit less sometimes, a lochia rubra, because during cesarean, we go ahead and do a lot of suctioning and try to get out a lot of blood, but she will have lochia because, again, she has to clean out that endometrium. And then you have a urinary catheter. Yes, I am going to monitor her intake and output, and then respiratory care, cough and deep breathing. Make sure, especially if she had a general anesthetic, you want to make sure that she gets everything out of her lungs. Prevention of thrombophlebitis. Okay, remember they're prone for a DVT, and so you want to do that Homan's test. And if it's a positive Homan's test, that means that when you looked at her calf of her leg, it was red, it's warm to touch, maybe some swelling, okay? And she has pain in the calf. And then when you dorsiflex her foot, she has pain. Not good. Okay, that's positive. So you're going to call the doctor, and you're going to get an order for a venous Doppler study and to rule out a DVT. Okay. Pain management, again, with cesarean birth, yes, they will have pain associated with, incision. Again, it's major surgery. All righty. So here's a good question. Which will the nurse anticipate assessing in a client following a cesarean delivery? And again, select all that apply. Okay. Well, I would definitely remember. Okay. So we're going to assess after a cesarean delivery, her incision and the dressing. Okay. Lochia, urinary output, vital signs, and fundal assessment. I'm going to do them all. Now, the incision site would be like the day, maybe after they maybe the second day, when the surgeon takes off the dressing, the big abdominal dressing, will take that off. Usually the surgeons like to take off their own dressing to make sure that everything is good. Okay. Now, which information will the nurse include when discussing Kegel exercises with a postpartum client? So Kegel exercise helps strengthen the muscles involved in urination. That's it. All right, so here is on the APGAR scoring. So this is your baby now. So your baby is born, and you're going to assess how he's adapting to extrauterine life. Okay, so you're going to look at appearance, the pulse, the grimace, which would be like your reflexes, and your activity, which would be your muscle tone and respirations. Okay. Now, you have points for each one of these. So 0 points is not good, right? It means your baby's in trouble. If you have 1 point, then you have like the trunk of the baby is pink and his face is pink, but his little hands here and his little legs, feet, especially the feet, are blue. All right. So this is called acrocyanosis. Okay, acrocyanosis. That's a good thing to remember. And so you're going to give him a score of 1 point. Okay. If he has a pulse less than 100, you're going to give him a point. If he has a pulse rate of greater than 100, as you can see here, you give him 2 points. Okay. So that's on the pulse. So you see back up here, acrocyanosis, trunk is pink, and his face is pink, but his legs and hands are blue. If he has a pink body like this, he gets 2 points. I just want to make sure I didn't skip over that. And then and here you have your pulse. No pulse is 0. Less than 100, you give him a point, and greater than 100, you give him 2 points. He's doing okay. Now, downward grimace is and another one is called reflex. And if he's floppy, we actually use that term called floppy, and he has no response, put it that way, then you give him 0. Okay. Minimal response, when he's stimulated, you give him a point because he is doing some type of response, but not very much. So give him a point. If this baby comes down, he's sneezing because he has a lot of fluid. You know, remember they're full of fluid. He's crying and, you know, he's pulling away, you know, he's moving around. I love that. I love when I hear my baby cry. That's 2 points. Okay. I always said when my baby cries in my room, in the delivery room, when I hear that cry, that's music to my ears. Sure is. Now, activity, muscle tone, no movement. He's flaccid. That's a term we use, flaccid. Then, you know, he's 0. Okay. Here he has his little arms are flexed and little legs are flexed. You can see they're up a little bit here. All right. That's a 1. Give him a 1. And he's moving. Look, he's moving all around. Isn't that great? Then give him a 2. Here under respirations, he's not breathing. That's 0. Probably 0 points. He has a weak or slow respiration. Okay, he's trying, maybe irregular, but he's breathing slightly. You give him a point, and then he's vigorous. He's got that beautiful, strong cry that I talked about. You give him a 2. So Dr. Virginia Apgar came up with this system so to let the healthcare providers know really quick how to resuscitate this infant. So a severely depressed infant would get an Apgar score of 0 to 3. You need to have that baby. You need to have NICU in there, RT in there. That baby needs immediate resuscitation. Okay. All right. And then moderately depressed would be 4 to 6. So you'd be doing some stimulation, you know, and getting him to respond. He might be moderately depressed because maybe mom got that drug during transition, which we tell you, you do not give a drug during transition. But, you know, so you need to have Narcan available. And then 7 to 10, you know, again, you're going to dry the baby off. And just drying him off and putting, you know, a dry blanket on him with a little hat. I mean, that's all part of stimulating this baby. So moderately depressed from 4 to 6, they need stimulation in excellent condition. You're drying them off because remember, I do not want to cold stress in my infant. So this is the Apgar. So it's good to know what's going on with your baby and how you should respond. And you can see here, they use Apgar, A-B-G-A-R. And it's a new way of remembering. All right, let me go ahead and make this smaller. And here we go. Let's see. Oh, I'll make it smaller. Okay. All righty. Okay, there we go. Okay. So again, we're looking at heart rate, respiratory effort, muscle tone, reflex response to suction or gentle stimulation on the soles of the feet. I like to kind of flick my finger on the bottom of his little feet, and boy, I get a good response. Remember, and the skin color. Apgar is done at 1 minute and then 5 minutes, okay? And if the baby has a low Apgar at 5 minutes, he's going to go to NICU and he's going to have a 10-minute Apgar. Now, babies come out and you have to keep them warm, put it that way. You have to support thermoregulation. All that means is keeping the baby warm. Because remember, if baby gets cold, okay, that is called hypothermia. Now, hypothermia can lead into hypoglycemia, and respiratory distress. And the reason why is because babies use a lot of sugar to trying to keep themselves warm. So I always have my baby warm. So he doesn't go into have a problem with hypoglycemia. And I don't want to create respiratory distress in my beautiful baby. So I'm going to make sure that my baby stays nice and warm. And how I'm going to do that is what? I'm going to have a radiant warmer in the room, and it's going to be on before the baby comes out, and it's ready to go. And I'm going to have the infant bracelets, the ID bracelets on before that baby leaves the labor room or the operating room. There's 4 parts to that bracelet. 2 are for infants and one's for mom and one's for her partner or her husband. And it has a number. And all those numbers have to match. And if they're not, then, you don't want to give the wrong baby to the mom, okay? So that's how we identify who belongs to whom. And so everyone has to have a matching number. All right, and then nursing care of the newborn, you're going to look at gestational age evaluation or using the bowel score. This happens in the nursery. And what they're doing is they're seeing, according to skin, is a lot of vernix on the baby, is there any langugo or hair, how are the ears set, are they soft, are they firm? And then you have breast tissue and the genitalias and then soul creases. This all goes into the evaluation of the newborn. And we can determine exactly how many weeks gestation this baby is. Okay, it's a good way of knowing if it's supposed to be 40 weeks, then it should have a bowel score that shows 40 weeks. Okay, so which security measure will the nurse take when bringing the client's newborn from the nursery to the mom's room? So, okay, so do you ask the parent, is this your ID number? Or do you confirm the room number of the mother? Ask the mother to identify herself verbally. She can tell you that she's Mrs. Jones, but is she really? But the best would be verify the infant ID band matches the mom's ID. And that's what I just said. All right. It's always good to know the normal vital signs for the infant. Because like on a HESI question, they could give you a big scenario and you need to know what's normal in order to pick out the abnormal. And then you do the interventions for the abnormal, okay? So normal respiratory rate on an infant is 30 to 60 breaths per minute. The heart rate we already talked about is 110 to 160. And then you want to, when you're doing the heart rate, we do an apical count, and we count for 1 full minute. Temperature, 96.8 to 97.7 is your skin. And then from 97.7 to 98.6 is axillary, which is most commonly used. We don't do a rectal, nurses don't do a rectal temperature, okay? Too many problems came up because that nurses were putting the probe way too far into the rectum and things can happen. Okay, so if I had to ask you, which of the following interventions best promotes bonding following a delivery? So with singing to the infant, well, that's kind of nice, but it's not the best, right? Skin to skin contact with mom, that's the best. That promotes bonding, which is that attachment that you want to create right after birth, okay? Breastfeeding, we'll go over this real quick. Breastfeeding, well, we always say breast is the best, but I want to give that choice to my patient. But I do tell her, if you breastfeed, you can have 500 extra calories. Another way to get them to breastfeed is that involution process that we talked about. They have more contractions, they have more after pains, but they contract a lot quicker, and they can get back in their skinny jeans. So if you have a young person that had a baby, they always want to get back in their skinny jeans. So breastfeeding will help them do that. So it's kind of nice. So there's two hormones that patient produces from the pituitary that causes, like, one is causes the production of milk, which would be your prolactin. And then your second one is oxytocin, which causes actually the milk ejection, or we call that the letdown from the alveoli down the ducts to the nipple. So oxytocin's really, 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 really busy, aren't they? And think about it. So when she breastfeeds right at the delivery and she's producing her own oxytocin because of the letdown, she's now giving herself some more extra contractions. So that's why the involution process goes down quicker. Also, if you got a patient that maybe has a lot of lochia, you want to make sure she contracts even better, you can have a breastfeed. Isn't that great? So oxytocin causes the letdown, and prolactin causes the production of milk. Okay, good things to know. The composition of milk, you have foremilk and the hind milk. The foremilk is the first milk the baby will obtain, which has the colostrum, okay? So the colostrum has protected antibodies. That's a good thing to remember. So colostrum, which is your foremilk, it looks thin, all right? Because it doesn't have a lot of sugar, it doesn't have a lot of fat to it, but it has those beautiful protective antibodies. If anything, we want the baby to get those because babies are only born with passive immunity for like 1 month from mom. That's it. So you want to get this antibodies that are going to protect the baby from getting sick. So that's from the colostrum. Now, from the colostrum, about 7 to 10 days after birth, she has more transitional milk. And so that has the sugar, lactose, has calories, and has some fat in it. Again, not a lot of fat that baby can't digest it easily, but enough. Okay, so it's good for babies to have a little bit of everything. And again, breast milk is easier digested by the newborn. Okay, they have less stomach problems because they're being breastfed. All right, now mature milk comes in, and that's usually like 14 days after birth. And again, now it's settled in, so now it's a little thinner, but it still has the calories it needs and all the nutrients it needs. And so now mom is getting used to the breastfeeding. She's breastfeeding every 2 hours. It's kind of demanding. 2 to 3 hours is kind of demanding. And moms know when they need to feed because their breast will get full and they have to release that. So if I was to ask you, the nurse is discussing the different phases of milk production with a patient, okay? So which phase of milk production will the nurse refer to when talking about the phase of milk production that contains the protective antibodies? And I hope if you're homes, I hope you say colostrum, B. Okay. Okay, so we're going to assist the mom to breastfeed. That's what we do. And we have nurses that are well trained to do this in addition to us, okay? And they're called lactation nurses. They go through, they're RNs, and they go through more training, and they take a certification, and they are lactation consultants, okay? And we all, though, help promote mother-infant bonding. That's what we want them to breastfeed, is because it's a special time between the mom and the infant. And we have that, and they have that close bond, which is so important for the psychological development of this baby. Then maintains infant temperature. Okay, we want to keep the baby nice and warm and maintains it. Sucking stimulates the oxytocin, remember I said, and releases to contract the mother's uterus. And that's a really good thing. And sometimes they have some cultural use of this glycotide, which are substance that promotes lactation in humans. Sometimes I've had a patient that was having a tough time getting, her breast, I guess the milk to come in. And so she went to this real natural store. And so she was able to get this and it helped get the start of lactation. Okay. Again, nurses, we are culturally respectful of all practices. When I had that patient told me, that's fine, okay, because I knew what she's talking about, and I knew that she wanted to breastfeed. So she did that and it helped, and therefore, no problem. Okay, again, non-judgmental. All right. Positions and breastfeeding techniques, we want to make sure that the baby gets a good latching on, has a good sucking pattern. And I'm going to show you how to remove the infant from the breast. So let's go here. So this is a picture of the latching on. So you can see the areola here. So mom's got the baby in a nice position. She's got like a cradle position here, and she's going to guide her breast into the baby's mouth. Sometimes you can get a little bit of colostrum milk to come out, and that kind of entices the baby. It's like, okay, there it is. And here she's guiding more. And here now, the baby gets on. So this is proper latching on, where the areola, which is this area right in here, the brown area, is in his mouth. So you can see here, okay? And you can see here, here's your palate, and here's the gum, and areola and breast tissue with underlying milk ducts. All right, everything is there. And here's the lower lip, okay, lower lip, getting a good hold on that whole area, and not just the nipple. Because if this baby just was sucking on the nipple, that nipple would get cracked and start bleeding, and what that leads into mastitis, which is an infection in the breast. All right. So here now shows you that you have to break the suction. So mom puts her finger inside his mouth, okay, and breaks the suction, because you don't want to pull that baby off the breast. That would hurt mom and cause another, and could cause an inflammation, and therefore then could lead to a most serious condition, again, mastitis. So you want to teach them, to break the suction. You want to teach them how to put the baby on the breast for proper latching, and how to take the breast off by breaking the seal, in order that she keeps breastfeeding, obviously, so that baby gets the requirements he needs, and mom stays healthy and she doesn't get mastitis. Okay, let's just go to the picture of engorgement. So you can see here, this is just normal. This is not engorged. So you have normal, everything is normal. All your milk glands are all normal. But look here, this is ovulating. Everything got full. We call that full, and it gets hard. And, it's very uncomfortable to mom. So that's why, in order to prevent engorgement, you can apply like ice, okay, or cold pack in between feedings, which would take this down, which takes down the swelling. Okay, and then just before she's going to breastfeed again, you can make it, put the little warm compresses on, so that it's good for the baby, good for the letdown. Okay, all right, so let's see here. Now, this is an example of mastitis. And my put inflammation, but this is sore. You can see how red, how inflamed this is all. This is very, very painful. You don't want this to happen, because I tell you what, your patient's going to stop breastfeeding. Now, how do you know that the baby has enough? Because a lot of times we get questions like this. And so we explain to them about the letdown reflex. And sometimes it's like a tingling sensation with some milk dripping from the nipple. Infants nurse for about 15 minutes per breast. And it's a lot, 8 to 10 times per day, especially in the beginning. They need this, okay? And so two, mom needs to stimulate the breasts to produce the milk. So she needs to be breastfeeding often. And plus two, you don't want her getting gorged because, you know, maybe didn't wake up and like he should, and then so maybe mom doesn't want to wake him up, but then she gets heavy breasts, and that can be painful. So you want to tell them, you got to wake the baby up, even if the baby's sleeping, wake him up to feed. And then baby, usually they're very relaxed after feeding, because that's they're fed, they have the little tummies full, and so they may have some stools. The baby's getting enough fluid because the baby has you look at the diapers, make sure he urinated, and then you keep a count. Infants have like 6 to 8 wet diapers per day. That's how we actually go by. And we tell that to the mothers to know that they got enough fluid. Okay, so if I was to ask you a question, which of the following indicates successful breastfeeding is occurring? The answer would be the newborn has 6 to 8 wet diapers per day. Okay. Okay, I've got another question. Which nursing action best provides a postpartum client pain relief from breast engorgement? Okay, so like I said, a nice cold pack between the breastfeeding sections really helps with breast engorgement. And I showed you the picture of the milk glands. They get really swollen, they get full, and then the breasts get heavy, they get full, and so you don't want that to happen. Like I said, mom gives an additional 500 calories. Make sure she drinks a lot of fluids, because the more fluid she takes in, the more milk she produces. Okay. All right. Weaning, there is no best time to wean. So gradual is always prefer. And what you want to remember is that you eliminate the favorite feeding last. So usually it's the nighttime feeding, where it's very soothing to the infant. And so you want to keep that one. So I would not eliminate that one first. I would eliminate like the daytime feedings. Okay. And you eliminate one feeding at a time. Because you want the infant still to feel, comforted, and you don't want to just abruptly take them off. No, it means a lot to a baby when mom breastfeeds her baby. Okay. Alrighty. I'll let you read that alone. I kind of went over obstetrical procedures already. You can see that. Okay. All right. We already went over a lot of this. Looks like this is like, that was like repeating. Okay. So here, remember we talked about the different degrees in lacerations or episiotomies. So again, you want a fiber diet, high in fiber, lots of fluids to keep her, from getting constipated. Okay, you don't want a patient that has a 3rd or 4th degree episiotomy laceration be constipated. All right. I think I already did this one. So these are kind of things here. Okay. All righty. We talked about the psych array. Okay, I already did all these. Okay, so you can kind of look through and see yourself. These are kind of, I talked about tocolytics. Okay, tocolytic therapy, the goal is to stop uterine contractions. And we want to keep that baby inside. So the premature baby, remember I told you about magnesium sulfate, it's a tocolytic. So you want to make sure that, you look up these drugs, okay, magnesium sulfate. And let's see. I guess prolonged pregnancy, remember, it lasts longer than 41 weeks. And sometimes you have premature labor, sometimes you have post-term labor. These are just things that basically can happen. What happens with prolonged labor pregnancy is the placenta does age. It does get old. And so you want to make sure that we get this baby. Remember I talked about induction labor at 42 weeks. Okay, that's what we're looking at. Okay. these are emergencies during childbirth. I talked about these already, so if you want to look at these a little more, you can. Another drug of a tocolytic is that we would give. Don't forget, we give tocolytics to stop the premature labor, but we also can give mom betamethasone, which what happens is, okay, you have a preterm baby, okay, and so this baby could have a difficult time breathing at birth, okay, because the lungs are not mature enough. They don't have the surfactant that they need, which is a protein they need to make make breathing good. Okay, so we're gonna give them, we're gonna give mom betamethasone to increase fetal lung maturity. We give it in 2 doses, and it does help. So look that drug up too. What is betamethasone and why do we give it to her? We give it to her to stimulate fetal lung maturity. All righty. These are just some complications. And we talked about hypolimic shock already. Remember, the first sign would be tachycardia. All right, and this just goes over some nursing care. Remember, your patient, remember, you have to assess the fundus of the uterus. Make sure it is firm, all right? Because with a soft, boggy uterus, she can hemorrhage. Okay. I'm going to make sure that I do an accurate intake and output. I'm going to monitor her amount of fluid given to her and make sure that she's getting rid of it. You're going to always monitor for signs of anemia, all right? And then, of course, your lochia, which would be lochia rubra, you're going to make sure that it's it's just a flow of blood, which is, is cleaning out that uterus. As she contracts, and there's more of that come out, okay? More lochia that comes out. And when you're looking down the perineum, you want to always assess for the hematoma. Okay, and when you're doing a post-op on a patient, you're going to monitor vital signs and oxygen saturation. So early postpartum hemorrhage, some causes could be uterine atony, which is a uterus without tone, some lacerations or tears of the reproductive tract, or some hematomas. Those are your early postpartum hemorrhage. Uterine atony is a uterus without tone. It could be that she has a uterus that's overdistended, retained placenta fragments, or prolonged labor. That can cause that uterus to get tired, the prolonged labor. And so, she could have a problem with hemorrhaging after delivery. Okay, so what are some characteristics of a uterus without tone? It's boggy and soft. The fundal height usually is above your umbilicus. Remember, normally after delivery, they're at the level of the umbilicus and midline. This one would be above the umbilicus. Lochia is increased. The lochia rubra should be a nice, even flow, and it could have large clots. You got a problem. You got a boggy uterus. You got a uterine atony. All right. So we want to make sure that we check the fundus of the uterus, check where the height is, and check for lochia. That's what you got to do. All right. Okay. On this one, it says, which medication will the nurse anticipate prescribe to control postpartum uterine atony? And that would be Methogen. So that's another drug. So these are drugs I would say, I recommend you to look them up so you know them, okay? The nurse assesses a postpartum client and notices uterine atony. And so which action should the nurse perform first? And I hope you would say fundal massage, okay? All right, we already talked about lacerations in prior. And so if you want to go over this, you can. But usually the blood is usually brighter red than lochia. So it's really bright red. It's a laceration. And what it is it flows in a continuous trickle. That's what I've seen on tests. A laceration flows in a continuous trickle. Okay, so like a water faucet, it's trickling. Okay, you know, if you have a leaky faucet and all done, it just kind of trickles in a continuous way. Um, that's a laceration. All right. So what are you gonna do? You're gonna have seen by a physician, and they usually have to suture it up. It could be that, you know, the forceps were used, all right, and so therefore it causes the mom to have this little laceration up higher, maybe around the cervix and the vagina. It could be in the perineum. So it's the fundus is usually okay, you know, it's usually firm, but that's what gives you a hint. Your uterus is good. So, you know, all the training we're telling you, make sure you check your uterus. But you come back and she still has more blood, you know, you just cleaned her up and you put a clean pad and you check the fundus is good, it's firm, and then you come back in a little bit, like an hour, and she filled up the pad again. You got to bleed her, all right, and you got to be on top of that when you do your assessments. Okay, that hematoma I told you are painful, so we call that unrelenting pain, and I can tell you I can give you a Percocet, which is a strong pain pill, and she still would have pain. Okay. So it looks like a bluish or purple mass, and this could be in the vulva, on the vulva, or inside the vagina. And that could be because of birth trauma. Alrighty. So let me just go over subinvolution of the uterus is a slower than expected or failure of the uterus to return to a normal pre-pregnant condition. Okay. So it just means, remember, I told you involution should go 1 to 2 centimeters per day. It's like this is going very slow. It could be that she could have some persistence of locia rubra. She could have pelvic pain. She could feel heaviness. So we need to get at what's going on. Alrighty, so let me just go here. We already went over DVT, positive Holman sign is swelling of the affected limb, and it's true. All right. Nursing care to prevent a thromboembolism. Okay, so get them out of bed. Early ambulation and range of motion. This is the big one. This is even for your med surge. Early ambulation. Get them up, you know, and get them moving. All righty. Okay, so go over also what is preeclampsia, okay? And I talked about placenta previa, and the only thing I didn't touch on, I think, is preeclampsia. So be sure to go over that. Remember, you want to make sure that you follow the directions on the test. If it says round to the nearest 10th, it's the 10th. Okay, so here. So you had 2.45 milligrams. You run around to the nearest 10th. That would be what? 2.5, right? Okay. So it was the nearest 100th, and then is another one. Again, you want to make sure that you take it down either the 10th, the 100th, or the 1,000th. All right. And remember, you know, your formula for D over divided by H, which, so what you desire divided by what you have on hand times quantity. And so you get your answer. Okay, if you don't remember this, then you want to basically go over this again, okay? All right. There will be one of these, calculate the intake output. All right, so this is why we study what we do, is to make sure that we have a healthy mom, a healthy daddy, right? Daddy's happy, we have a family, and we have a healthy baby. Okay, so I'm just checking here. Go over that worksheet we have for you. Is a worksheet for chapter 6, 7, 8, and 9, and it'll help you. And again, preeclampsia is hypertension in pregnancy, and we give magnesium sulfate to prevent a seizure, and go over the nursing actions. I went over locia, making sure went hyperventilation. You know what Narcan is. We know what true labor, false labor, when bloody show, 4 stages of labor. I think we conquered quite a bit. So make sure that you look at the PowerPoints that already you have, and do this worksheet. And if you're doing the worksheet and you cannot answer these questions, there's like many of them here. Then go back in the textbook and look it up, okay? And keep that worksheet for your HESI review too when it comes time. There are 73 questions on this worksheet, and it will guide you as to what you need to be looking at, okay? And these chapters, a lot of chapters, a lot of information. All righty. So I want to say good night to you, or right now it is my nighttime. So anyway, you have a good night, and keep studying. Please look at the Kahoots. They're really good. And look at all the PowerPoints, your textbook, your key terms, your key points, and you'll be very prepared for the exam. Okay? All right. Bye, everybody. This is Professor Dunham signing off.